Good afternoon, everybody, and welcome to our IDF Europe webinar with the MMD group. I'd like to welcome all of you. This is the year of the centenary of insulin. We've just celebrated in November. We celebrated World Diabetes Day. We celebrated the insulin discovery and the next 100 years. We're very grateful to our very august panel today for joining us on this webinar. And without much ado, I will introduce you to the first speaker. The run of events is one of our MEPs, Crystal, who is the co-chair of the MEPs Mobilizing for Diabetes Interest Group, will kick us off. We'll get a testimonial with a person with diabetes, and Marche, who's a type 1 diabetes advocate and has been for many years, will be the second speaker. We'll then have Professor Chantal Matthew, who is the UDF president, and she'll be talking to us about the types of diabetes, causes, symptoms, and Q&A. I'll talk a little bit about the burden of diabetes in Europe. We'll have an implementation in Europe of Global Diabetes Compact with Jill Farrington. Thank you so much, Jill. We're going to be talking about the relevance of diabetes EU programs with Sabine Dupont, who works with us. And then we'll conclude with Sirpa, who's one of the co-chairs of the MEPs Mobilizing for Diabetes Interest Group. So thank you very much. I'll hand over to you, Crystal, to kick this off. Thank you.
Thank you so much for this, and welcome everyone to this webinar. We're going to talk about diabetes, and that's a thing that I've been working with for many, many years as a member of the European Parliament. And I am a co-chair of the members mobilizing for diabetes in the European Parliament together with Sirpa Petikän. And it's a cross-party organization. We think it is important to highlight the need to work for improving the situation for patients with diabetes, but hopefully also at a certain time find the cure. But meanwhile, we need to make sure that we can improve the life quality of people with diabetes and hopefully also do something to make sure that fewer people are getting diabetes in the area where we can do something. Anyway, welcome here today. And as we just heard, we also kind of still keep on marking the 100 years anniversary of the discovery of the insulin. And I read a little bit about it again, just to remind myself about it. And I think, of course, it's a truly important discovery, but I also, once again, saw as important is that this spread of the use of insulin and the fact that we got the insulin was also due to a cooperation between many scientists. They were sitting in each of their part of the world, but they ended up sharing and helping each other. Of course, sometimes also competing, but in the end, it was really a shared effort that made it possible for people to live a better life with diabetes due to insulin. And I think we need to look into how about the next 100 years, what can we do? So we are here today, and I think it is an important time, and we are discussing health questions much more due to the COVID-19. But I also think that should be used as an opportunity for us to discuss much more about health questions. What can we do? What should we do? And luckily, the Commission, EU Commission, has also come up with a new initiative. In the beginning of this mandate, they focused very much on cancer, and now they made a new initiative concerning non-communicable, I can never say that word, non-communicable diseases like diabetes. It's called Healthier Together. And I think even though it's a little late, and even though it should have been a part of the first process, I still believe that the title Healthier Together makes it important for us to work also to highlight the need of having a focus on diabetes, because this is a part of it and we can do so many things together. So I'm really happy that we at least see some new changes. And I think we here in the European Parliament, together with all you stakeholders who know so much about the topic, should push for some specific topics to be dealt with in this work when we have to work on Healthier Together. And for me, I do believe still that it is possible to make a better everyday life for citizens, for patients with diabetes, And I do believe that it is impossible also to prevent more cases. So we need to learn from each other, and we need to have a higher political focus. And if we do that, then we can hopefully by the end of the day make it together and make us all healthier together. So welcome to this webinar. I'm looking forward to listen to all the good people who are going to help us learn more. And together with Sirpa Pietikäinen, we will also in the NEPS Mobilizing for Diabetes try to bring some of your good ideas into the next part of the process. If we shouldn't act now, then when? So we need to start working. Thank you and welcome.
Thank you so much, Crystal, for that great introduction. I'm going to hand over to Marche. Marche, your turn. You've been living with diabetes, with type 1 diabetes for many, many years. Your perspective perhaps is the most important one here. So we'd love to hear from you.
Thank you so much, Niti. Hello, everyone. I am Marche Roskans, and I am living with type 1 diabetes and also with epilepsy for several years. Together with my family and my friends, insulin is my most important lifeline. And currently, I am 25 years young, diagnosed at the age of 15 with diabetes, and I have been living with the condition for already 10 years, and I will be living with it for the rest of my life. Diabetes requires round-the-clock management 7 days a week in order to survive. It is estimated that people living with diabetes make an extra 180 health-related decisions a day. This means that as soon as I wake up, I'll have to take decisions for my diabetes every 5 minutes on an average. And unfortunately, diabetes doesn't go away when I go to bed. More specifically, 2 days ago, I thought that I made all the right and responsible decisions to go to bed and survive the night. I was at the end of the most amazing Saturday where I sent a message to my boyfriend telling how much joy of life I gained out of my day on my own, cycling, shopping, catching up with a friend. And I shared with him how lucky I was to be alive, because it was a long time ago that I felt so calm and great. And I couldn't wait telling him everything about that day, a day later when I was going to see him again. I lowered my insulin more than usual to be sure I would not drop low, because I'm always more scared during the night when I'm alone. And as usual, I also checked my blood glucose levels to make sure that it's safe to go to sleep. And so I thought that my daily job of making responsible decisions was completed. A few hours later, out of nowhere, something terribly went wrong and my blood sugars dropped below 30. And so life almost slipped away, being alone in that bed. 25 years young, and the day after, I almost did not have the chance anymore to tell my boyfriend how lucky I am to be alive and how much I love him. This constant attention to diabetes on a daily basis and the fear of hypoglycemia, the perspective of long-term complications, that represent an important psychological burden for me, but also for many other people living with diabetes. Today, I am very grateful to be here, being able to tell the story, but on the inside, I am still devastated about the fact that diabetes is so much out of your control, despite all the efforts that we put into it all the time. Together with the dropping blood glucose, so much joy of life faded away. And in just a few hours that night, I went from living my life to the fullest to a life right now on pause, because I'm scared of every future decision that I need to make right now. What if it goes wrong again? What if I'm alone again? And it's true that since the discovery of insulin, much has been achieved in terms of medical advances and new technologies. And these have transformed diabetes management and improved the quality of life for both living with type 1 and type 2 diabetes. And I am definitely amongst one of the lucky ones living in Belgium with great access to care and technologies. But much remains to be done, not only to ensure better medical outcomes, but also so many other fields, such as avoid discrimination at school and on the workplace, to improve access to healthy and affordable food, to support urban planning that promote active living, to improve access to technologies, and to increase digital literacy, for example. Decision makers, policymakers. Today, I am here to tell my story because I think that this isn't the way I'm supposed to feel as a young person. We, people living with diabetes, need help, need access to care, and need support to manage our 108 daily decision making, because the weight is too heavy to carry on one shoulder. Thank you, everyone.
What a moving story, Marjorie, and thank you for sharing that with us. I have a son with type 1 diabetes, you know him, right? And as a family, I'm sure your family just feels the same as we've felt for the last 30 years. So thank you so much for sharing that story. And I hope everyone's listening to what Marjorie is giving out as messages. We'll pick those up at the end. Thank you, Marjorie. I'm going to move across to Chantal. So Professor Chantal Matthew, who's been a lifelong advocate for diabetes. She has she's published numerous publications. She works tirelessly on research. I'm delighted to welcome her here today. Over to you, Professor Matthew.
Thank you, Niti. Thank you, Dr. Pal. And I'm humbled, honestly, to talk about diabetes after this amazing testimony by Maartje. And I also know your son, Niti, as an amazing person. And I respect what people with diabetes live every day. So my task now is to briefly introduce to you what is diabetes. I am an endocrinologist working in the University of Leuven here in Belgium. And let me start by just reminding ourselves what happens to glucose when we are eating. So when we are eating, glucose will move into the blood, and we need a hormone, namely insulin, which is being manufactured in the pancreas, namely in the beta cells of the legendary islets of Langerhans located in the pancreas. And so insulin is made in reaction by these beta cells and is released as a reaction to food intake into the blood. And this insulin will allow the glucose to be taken up into the target organs, being the body fat, the body muscle, but especially into the liver. And when we talk about diabetes, we actually talk about a very mixed bag of diseases that all have in common that they make blood sugar rise. And it is as long as 1500 years before Christ that the ancient Egyptians already described a disease that was characterized by loss of glucose, loss of sugar in the urine. Because indeed, if your blood sugar rises, your blood is being filtered by the kidneys and sugar will appear into the urine. And so this name, diabetes, coming from the Greek word diabein, means running through. So it was like a siphon running through with glucose into the urine. But it is actually, now that we know more about the pathogenesis of specific diseases, it is a group of diseases, and they all have in common this hyperglycemia, high blood sugar levels, but it's much more than sugar. It is actually a syndrome characterized by abnormalities, both in glucose metabolism, but insulin also turns out to be key in protein and in fat metabolism. And we know many diseases that are known within this diabetes mellitus family. Now, we have specific criteria to talk about diabetes mellitus, for instance, based on a fasting glycemia or based on a challenge glycemia with 75 grams of glucose, oral glucose tolerance test. When we have values, fasting values above 126 milligram per deciliter, or after this challenge above 200 milligram per deciliter, we can talk about diabetes, especially in symptomatic individuals. If you do not have symptoms of diabetes, you need two of these values combined. Now, what are the forms of diabetes? The most to the imagination speaking form of diabetes is type 1 diabetes, because it will mainly affect for the first time young children, adolescents, young adults. But it can also affect adults of all ages. But so this is the form that needs insulin for survival. But the majority of people we know with diabetes will suffer from type 2 diabetes, a very different disease I will briefly come back to. Now, we also have other forms of diabetes. For instance, diabetes because of pancreatic abnormalities, people who've lost their pancreas due to a cancer, or people who have had pancreatitis, an inflammation of the pancreas. We also have more and more forms of diabetes that we can explain by one gene, the monogenetic forms of diabetes, but also some people have diabetes because of treatments they receive for other diseases. And typical here is, for instance, cortisone. But also very well known is gestational diabetes, a form of diabetes that appears for the first time during pregnancy and disappears with the delivery of the baby. But we now know that this form, gestational diabetes, is actually a far relative of type 2 diabetes. And women with gestational diabetes are the population at the highest risk of developing type 2 diabetes later on. Now, these are the forms of diabetes we know, but we know that as research progresses, as evidence progresses, we are identifying more and more causes of this very heterogeneous bag that is diabetes mellitus. Now, here to give you a picture of what type 1 diabetes is. In type 1 diabetes, our immune system is destroying the only cell known in our body that can make insulin in a controlled manner. And so when you do not have enough insulin, when you have insulin deficiency, you do not have enough of this insulin to push the glucose into the target organs, and you will get hyperglycemia. You will get the diabetes mellitus. Type 2 diabetes, very different disease. These individuals still have most of the time, a lot of insulin production, but the insulin isn't allowed to move into the target organs. There is insulin resistance in the target organs. Why is there insulin resistance? A typical reason for people to become resistant against the action of insulin is aging. Another reason is a sedentary lifestyle. So muscles who do not move or that do not move are resistant to the action of insulin, but also obesity. The accumulation of fat into liver, into muscle, for instance, makes these organs resistant against the action of insulin. And hence this explosion of type 2 diabetes worldwide because of the aging of the population, but also because of the increasing sedentary lifestyle and the increasing percent of people living with overweight and with obesity worldwide. Symptoms of diabetes, typically because of the rise of glucose or sugar in the blood. I told you that the blood is filtered in the kidney, so you will start to lose glucose in the urine. This is called glucosuria, but we cannot pee out sugar cubes. We are sucking free water together with the sugar into the urine, so we lose fluid also. And so this causes excessive urination and also thirst, dehydration. Because of the disruption of the input of glucose into the target organ, but also the disruption of fat and protein metabolism, you get a progressive wasting of the body. You get fatigue, you get weight loss. And then because of the hyperglycemia itself, bacteria, yeast love to live where it is sweet because then they have energy. So there is this problem of an increased risk in bacterial and yeast infections. Now, one caveat is that many people, especially with type 2 diabetes, which is a slow onset disease, many people with type 2 diabetes will not have symptoms until it is too late, until they have lived many, many years with increased blood sugars, slightly increased blood sugars that are dangerous. Why? Because they give complications of the disease. Why should we worry about diabetes? We know many, many very famous people who live and have lived with diabetes and have very fruitful lives. But why do we worry? First of all, IDF publishes every year the data on diabetes worldwide, and we'll be coming back to this later on. There is an increase in the numbers of people living with diabetes, especially in the emerging economy countries. But also, and Maartje said it wonderfully, and I use this slide to just show the burden that is diabetes. Here I show the burden of type 1 diabetes, and Maartje voiced it even better, this decision-making every moment of the day. But also, and we have to realize this, that diabetes costs life years. Here I show a study on type 2 diabetes looking at the life years lost in women and men living with type 2 diabetes in this study. And you see that there is a difference compared to individuals not having diabetes. And the younger people with diabetes are the bigger the differential, and especially in women. Why? Because especially for cardiovascular disease, which is the major cause of mortality in individuals with type 2 diabetes, women without diabetes are protected relatively compared to men against cardiovascular disease. And diabetes wipes out this protection. And so the differential in women is even bigger than in men. Why is this increased mortality? I already alluded to this cardiovascular mortality, but there's many more complications to diabetes, because indeed, if you live many years with an increase in your blood sugar levels, your vessels will be affected. Your arteria, your small vessels will be affected. The vessel of the eye, diabetes is the leading cause of blindness in Europe, as you can see here, but also the small vessels in the kidney. Diabetes is the leading cause of end-stage renal disease in Europe. Also, the neurons, so the nerves are being affected, and here again, diabetes is the leading cause of non-traumatic foot amputations in Europe. And then, as said, this more than double risk of stroke, myocardial infarction, and cardiovascular mortality. And so diabetes is the sad sixth cause of mortality worldwide. And here I just show you a figure that you can also find on your own website here, where they looked at the top causes of mortality globally. Here, the year 2015 in burgundy and the year 2030 predicted in blue. And you see that diabetes is the sad champion that is now beating the lung cancers, for instance, in the sequence of causes of mortality. Now, I talked about type 2 diabetes. This is the majority of people living with diabetes worldwide, with the aging, the overweight and obesity, and also sedentary lifestyle at the basis of type 2 diabetes, but also type 1 diabetes, the disease that is caused by a destruction of the beta cells and where people need insulin for survival. Also in type 1 diabetes, there is an increase in life years lost. There is still a differential of about 13 years between people with type 1 diabetes and people without type 1 diabetes. Again, cardiovascular disease is a reason, but also, as you can see, at very young age, there is a differential between those with type 1 diabetes, men and women, and those without type 1. Why is that? That is not because of chronic complications. That is now because of acute complications. Ketoacidosis, for instance, a specific complication to type 1, but also hypoglycemia, a side effect of our treatment. And Maartje really illustrated it so nicely that indeed hypoglycemia still occurs despite all of our fantastic treatments. So how to tackle this disease? Here I took a silhouette of Napoleon. It is attack and defense, namely it is prevention and better treatment of diabetes. Type 2 diabetes prevention, absolutely. And this is right in your area of the members of the European Parliament. It is general population measures. It is the making the environment such that healthy food, that exercise, etc., is being promoted. Living healthy together. But also screening and targeted lifestyle measures for those at risk. There are these typical risk score charts that you can use to find your risk. And then finally, therapy, a holistic approach, not only glycemic control, but again, lifestyle modification, blood pressure control, dyslipidemia control, etc. In type 1 diabetes, general population measures, we still do not know how to prevent type 1 diabetes. We know we can screen for an increased risk, genetic or presence of autoantibodies, but that is at the moment still in the realm of research projects. And I'm proud to be part of research projects that are supported by the European Union. In Europe, we have this GPAT initiative where we are screening neonates for an increased genetic risk of type 1 diabetes. And also the INODIA project, where we're looking specifically in family members of people with type 1 diabetes for autoantibodies and trying to better understand what is type 1 diabetes. And then the therapy, it was already alluded. It is exactly 100 years ago that insulin was used for the first time in a person who was dying from type 1 diabetes. It was on the 11th of January that they gave it for the first time, but it was on the 24th of January that they gave it for the first time repeatedly. And we have come a long way from the horrible glass syringes and big needles and not being able to measure glucose, etc., to now having sensors, having analogs, having pumps, etc. But still, as Marcia illustrated, it is still, and pardon my words, a shitty disease. And so I do hope that indeed you all read the blueprint for action on diabetes in the European Union, where we emphasized also the importance of research. And this is in the realm of the European Parliament. And so I'm very proud to say that Europe, the European Commission, has done a lot already to support research in diabetes, and I hope you continue to do so. And I want to salute especially the public-private partnerships where this INODIA project is a part of, where we are able to work together between academics, people living with the disease, and the industry to try and tackle specifically type 1 diabetes and hopefully one day prevent and arrest the disease. So I tried to be brief, Niti, and hope to answer questions that may arise at the end of today's webinar.
Thank you, Chantal. You certainly were, and you've given everyone a lot to think about. A very, very concise presentation. Thank you so much. I think it's my turn now, and I shall try and keep it brief because Chantal has done a really great job of presenting some of the facts to you in Europe of what's going on. So I'm Dr. Niti Paul. I'm a primary care physician by trade, and I'm the chair of the International Diabetes Federation for the European region. Could you get to the next slide, please? Yeah, so Chantal alluded to this. This is the prevalence of diabetes in the European Union. 31.6 million, 1 in 10 adults live with diabetes in the EU. We think this is significantly underreported. The number is forecast to increase to 33.2 million, size of some small countries. So there's a lot of people with diabetes across the European Union. 1 in 3 patients with diabetes is undiagnosed. You only hear about them when they actually get to get complications. We know that diabetes reduces life expectancy up to 10 years. Chantal's touched on this. 1 in 7 live births are affected by hyperglycemia in pregnancy. And children born to women with hyperglycemia have very high risk of obesity and early onset type 2 and CVD. So it continues through life. And the European region has the highest number of children and adolescents with type 1 diabetes. So we know that this is a problem. Next slide, please. And the diabetes related complications you heard from RJ, it's not just the complications, it's having to live with the condition day in and day out. It's a leading cause of blindness and lower limb amputation. We know that patients with diabetes are 2 to 3 times more likely to have cardiovascular disease. leading cause of kidney disease, and it affects the mind just as it does the body. And Marcia brought that into focus, didn't she? She talked about how she felt about not being able, she may not have woken up, and the fear that you live in. It requires the lifelong 24/7 management, and depression is 2 to 3 times more common in patients with diabetes than the general population. We're seeing more and more of that as it's being picked up. Next slide, please. Just bringing us back to where Chantal left us, and she talked about the impact on health systems, and Jill will pick this up in her talk from the WHO in Europe. Europe has the world's second highest health expenditure per patient with diabetes. And patients with diabetes account for third largest number of potentially avoidable hospital bed days spent in Europe amongst chronic diseases. It's a big number. We saw health systems got overwhelmed during COVID. It's not over yet. And people with diabetes were more at risk. I'll talk a little bit about that in a minute. And the diabetes-related health expenditure in the EU was 104 billion euros in 2021. Yet, about 75% of diabetes-related expenditure is due to potentially preventable complications of the disease, which is why we've mobilized our lovely MEPs to actually raise the issue. We're hoping that this will bring into sharp focus the economic burden of the condition as well. And cost-effective prevention has been clearly demonstrated by freeing up health system resources through lower diabetes incidence, broader access to health to cost savings, and ability to reach previously underserved communities, such as people in deprived areas and in rural areas. Next slide, please. And we published a report on your right. It's living in COVID times. These were experiences from people living with diabetes during COVID times. It brought sharply into focus people with chronic diseases, particularly with diabetes, heightened risk of developing more serious and deadly form of illness. COVID-19 has disrupted access to care and essential complication screening and diagnosis, where you do need to go to get your eyes screened or your foot looked at, or just someone to examine your heart. You need all of that doing. If that hasn't happened, this can lead to severe complications. This disrupted that treatment completely. The burden associated with lockdown measures imposed in many countries constrained people's ability to exercise, eat healthily, and caused huge psychological distress. And we found this theme emerging across every country, every country we spoke to in the EU. Next slide, please. And there is a stigma imposed on this, and the public narrative can really reinforce this. This lack of general awareness about diabetes amongst the public and many health professionals and some policymakers is thought of as a self-inflicted condition. And Chantal told you, she told you why it happens. And assuming that personal behavioral choice is the primary determinants of developing the disease, it's not. And stigma hinders prevention campaigns, creates barriers at nearly every step of the way, and engenders discrimination beyond the health system, at school, in the workplace, and many daily activities. I've heard so many stories about kids not being taken on school trips, being excluded from swimming and sport because they're worried about this, and people with type 2 diabetes were excluded from the workplace as a result. And the fear of judgment and discrimination can discourage individuals from actually talking about the illness, telling their colleagues about it, undergoing screening, delaying diagnosis, and negatively affecting diabetes management. Next slide, please. Next slide, yeah. So it's a significant burden for individuals, but financial, emotional, psychological, society at large, and health systems. But we know with the right policies, management, and risk reduction programs, care and uninterrupted access to appropriate treatments, tools, and technologies, people with diabetes can lead long, healthy, happy, fulfilling lives. And that's what we're asking for in this group. Next slide, please. Thank you so much. And I will hand over now to Jill Farrington. Thank you very much, Jill, for joining us. It's you've taken your time out to be here today. I know you're really busy at the WHO. So we really thank you for being here. You're going to talk about the Diabetes Compact and how it's being implemented in Europe. Thank you so much.
Thank you so much, Niti. Thank you. Everyone's busy. It's a real pleasure to be here, and thank you for inviting me. I just get the slides set up. So as mentioned and as seen there, I'm the Regional Medical Officer for Cardiovascular Diseases and Diabetes in the European Office of WHO, and I've been asked to introduce the Global Diabetes Compact. Thank you. So the Global Diabetes Compact is a global initiative developed by the World Health Organization in partnership with a whole range of different stakeholders, which was launched last year. And it has a key aim to reduce the risk of diabetes and ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality management. So a huge aim, but let's see how they're going about that. Next slide, please. So as I said, it was launched in 2021, again, coinciding with the centenary of the discovery of insulin. It was launched at the Global Diabetes Summit, and it brings together national governments, UN organizations, non-governmental organizations, private sector, academics, philanthropic foundations, and importantly, people with diabetes themselves, and people and families with lived experience of diabetes have been involved in designing this initiative. In a second, I'll talk about some of the work streams, but just to say in terms of governance, there are certain mechanisms for connecting WHO with these different stakeholders. So for example, looking at the work stream at the bottom, it's fine. The next slide's fine. Thank you. This one is fine. For governance, there is a technical advisory group on diabetes, which also includes people living with diabetes to advise WHO on its leadership and coordination role in this area. And it's also established a Global Diabetes Compact Forum to share and disseminate ideas, information, and views to further the advocacy of the work. There's also some very practical work streams. So working to increase the access and affordability of diabetes medicines and health technologies, working on technical products to assist countries and different partners, for example, a global price tag and targets, which I will speak about in a moment. It's broader work in tackling obesity, improving nutrition and physical activity, health promotion and prevention, support to countries, and also research and innovation. Next slide, please. Another important event last year was the recognition of the challenge of diabetes and the growing burden at World Health Assembly, which takes place each May. And in the World Health Assembly, the member states passed a resolution on diabetes, urging member states, where appropriate, to intensify their efforts to address the prevention and control of diabetes. The resolution also made certain requests of WHO and its Director General to, among other things, strengthen policy implementation, concrete guidance provision, monitoring diabetes responses within countries, and importantly, to report annually to the World Health Assembly on the progress that was being made. Next slide, please. This week takes place the Executive Board of WHO, and the Director General was asked to bring to Executive Board a set of draft recommendations for how it would go about, WHO would go about strengthening and monitoring diabetes responses and considering potential development of targets. And in this paper, which is available, you can't see the link, but it's on the slides when you get hold of them later. Within this paper are a set of draft recommendations for member states, international partners, and WHO, and a set of global targets. You'll see that for each of the recommendations, there are kind of 5 areas of work for each of those entities to address. Next slide. Within the proposed targets, a set of targets have been developed. This was developed by WHO with an academic group during last year, put out for consultation and then further refined. And these targets are not individual treatment guideline targets, but rather global coverage targets to capture areas of missed opportunity, particularly around diagnosis and treatment gaps. And they're intended to be ambitious, but also achievable and measurable at country level. And these would then be monitored on a voluntary basis with member states. Next slide, please. So what does this mean for the WHO region of WHO? And just reminding you that the European region of WHO covers 53 member states, not just the EU countries, but also extending all the way across to Central Asia, so 53 countries. So Europe, obviously, the European Office participates in the global activities, as do the European member states. And we have an opportunity to make sure that all of those work streams are relevant to the European region. They reflect European experience and expertise, and the benefits are also felt within Europe. So we can collectively work together on those pieces of work. And we also will see that the European member states will be monitored and assessed with regard to those global targets if they're approved at World Health Assembly in May, following the discussions this week at Executive Board. Furthermore, within the European region, just back one slide, we have developed this brochure describing some of the areas of specific areas of work that we will be doing ourselves within the European region. And I'll go through each of these in turn. Next slide. So in the first one around assessment, as I said, we'll be continuing to monitor the implementation of the global and achievement of the global targets, the original set of NCD targets, the SDG targets, Sustainable Development Goals, and also any new targets which are agreed in terms of diabetes. On a regular basis, we survey member states, and we will be doing more detailed analysis of our latest set of data, looking particularly at the policies and programs in place within countries, access to medicines, and we will be developing a report on diabetes by the end of this year, early next year. We will be assessing, supporting member states and countries to assess the quality of care within the countries. We have a range of different tools. For example, a tool we have on assisting in the clinical audit of case records, work that we've been doing on registries and information systems. We will also be assessing evidence. So we will be updating our evidence review on cardiovascular disease screening, which includes risk factors and diabetes within that. And we will also be commissioning reviews on prevention of diabetes and screening for diabetes, which will be ready later this year. Next slide. We continue in terms of our partnership work. These are just a number of the things that we've been working on or been involved with during the last year. Working with partners for synergy around core health priorities is one of the key features of WHO's European Programme of Work. So, for example, we've been working with colleagues from the EASD and the University of Liverpool on improving eye screening. We've been developing joint work plans with the European Diabetes Forum and International Diabetes Federation. Been working with foundations such as the World Diabetes Foundation, and we were very pleased to be involved last year at the launch of the Diabetes Blueprint and look forward to following through on the work on that. We also want to make sure that when we are working in countries, that these partnerships, and importantly the involvement of professional and patient associations and people with lived experience of diabetes, is also taking place as we develop programs. In terms of the technical support within countries, we have a range of work all the way through from prevention through to care and prevention of complications. And we will be taking up a number of opportunities to intensify this support this year. So, for example, on the left of the slide, these are different tools that we use for improving the cardiovascular risk factors and management of diabetes in primary healthcare. We will be updating our guide on therapeutic patient education as one of the means of supporting self-management of diabetes. We will be continuing to work together on strengthening health systems to get to the best outcomes for people with diabetes. And we will be working on prevention of complications and have issued a guide on diabetic retinopathy screening and been surveying the state within Europe. Next slide. We'll continue to take our opportunities to highlight this work, websites, social media, country case stories, but also importantly, together with our partners. We have regular meetings with our colleagues from IDF, for example, and we have an opportunity to try and intensify communications and highlight those wherever possible. Next slide. Oops. Yeah. And finally, around leaving no one behind. This is a strong emphasis within the European programme of work, and we already have mandates, for example, our men's and women's health strategies and our equity in health work, for example, in our Venice office, to try and narrow the gaps across Europe and within countries. We take the opportunities where possible, for example, with our gender and NCD report to highlight differences where these exist. And we will also be working particularly with our flagship programme on behavioural and cultural insights in the work that we're doing, for example, in countries. Next slide. So in conclusion, through the work that's been done in the Global Diabetes Compact, the World Health Assembly, and also this year, we hope in World Health Assembly, there is a strong global mandate for action on prevention and control of diabetes. Work streams are already underway from which we can benefit within Europe. And I think this, the phrase of our European Programme of Work, United Action for Better Health, is bringing exciting opportunities, working with colleagues taking part within this call and also within countries as we go forward. Thank you.
Thank you so much, Jill. That was a very comprehensive run through the compact. I'm sure lots of people have lots of questions for you at the end, but very beautifully presented, and we're so glad the WHO is taking such an interest in diabetes. Thank you so much. Sabine, I'd like to introduce my dear friend and colleague, Sabine. She's going to talk about the importance of some of diabetes in the EU program. Sabine, over to you. I'll let you introduce your topic.
Thank you, Niti. So I'm going to highlight some of the current initiatives related to diabetes within the EU. But first of all, I would like to outline the frameworks that are really required across the diabetes journey to make a real difference to the diabetes epidemic and to improve the quality of life and health outcomes of people living with diabetes. So essentially, when we look at the journey, there are many opportunities for action, and it all starts with prevention. So as Chantal explained, we cannot prevent all types of diabetes, but there are certain types, such as type 2 or gestational diabetes, that can be prevented. And type 2 diabetes, for example, account for about 90% of cases of diabetes. So there can be, there's a lot of scope for action there. The second opportunity for action is around screening and diagnosis. So if we have the tool, if we have the policies to detect people living with diabetes who are yet undiagnosed, if we act early when they are diagnosed, then we can really ensure that the risk of them developing complications in later life will be reduced. And post-diagnosis, obviously, there are a lot that we can do to improve the management and prevent those complications from arising. But there are two factors that are really important in preventing those complications and improving the prevention. And that's, first of all, the social and economic determinants of health. So essentially the conditions in which people live, grow, develop. The second one is having health enabling environments. Are you able to go for a walk? Are you able to access healthy food close by? And unless we act on those root causes of many cases of diabetes, we will not succeed in ensuring, in tackling the diabetes epidemic. So looking at prevention, what can we do? We can raise awareness amongst the general population, but also amongst the community actors, amongst healthcare professionals. If we have the tools, we can better manage the population risk, identify individuals early. With the right tools, we can ensure that people, once they're diagnosed, have the tools to manage their conditions effectively. That means having access to education, having peer support, ensuring that people have the right level of digital and health literacy so that they can really avail themselves of what they need. And a key part of that is obviously ensuring that people have access to the medicines, the technologies, the supplies they need to manage their diabetes properly. So how can policies help, and which kind of policies within the EU can help with that? Well, actually, there are quite a number of policies within the EU that can support action. And this graph is super complicated, and I don't intend to go through it in any detail, but this is just to show the range of policies that currently exist and which can be leveraged to ensure that the needs of people with diabetes are included in the right policies. So for example, if we look at the European Health Data Space, this provides a huge opportunity to ensure that data is properly shared for the benefit of people with diabetes. But what it means is that we need to ensure that we have, for example, diabetes registries. So we need to ensure that all stakeholders come together and act to ensure that we have the right tools and policies in place within the EU. So we don't have very much time, so I'm just going to go very quickly through the policies and how they matter. So for the social and economic determinants of health, there are actually two main initiatives within the EU that are very important, and that's the EU for Health program and the recently launched EU NCDs initiative, which I will discuss a bit later in this presentation. And why that matters is that we know that the social determinants of health account for up to 50% of health outcomes. And we also know that the prevalence of diabetes is very much higher in more vulnerable population groups, in people with lower income levels, with lower educational achievements. And again, that was brought to the fore very clearly with COVID-19. The prevalence of COVID-19 and NCDs reflect social inequalities. With regard to improving access to quality diets and physical activity, the two programs that can make an impact are the Farm to Fork program and Healthy Lifestyle, which is a 2-year program by the EU. And Farm to Fork really aims to improve access to nutritious food and make people able to make informed choices when deciding on which food to buy. For health enabling environments, actually, most of the EU policies and programs look at supporting cities in having better regulation, in sharing knowledge, in getting more funding, and in implementing action to make sure that they can help support and achieve the Sustainable Development Goals. And again, this is quite important because we know that urbanization has been a major contributor to the rise of type 2 diabetes, and over 70% of Europe's population live in urban areas. As was clearly explained before, diabetes carries a huge psychological impact, but we also know that mental health issues make the management of diabetes more complicated. So again, the EU NCD initiative can play a big part in supporting mental health for the benefit of people living with diabetes. And the European Parliament is also working on a number of different initiatives that can support that goal. One of the most recently announced initiative by the Commission is the European Care Strategy, which is included in the Commission Work Programme 2022 and is expected to be published in Q3 2022. And it will look at implementing sustainable long-term care strategy. And the reason this matters is that, as we've seen with Marcia and with the little girl that Chantal mentioned, you can actually develop diabetes when you're a baby. And you will live with diabetes throughout your life until you're much older. And the needs that you will have and the needs of the carers will evolve over time. But probably some of the most impactful initiatives or recent initiatives by the Commission are those that deal with innovation, data, and digitalization, and notably the European Health Data Space, the European Artificial Intelligence Act, and the European Pharmaceutical Strategy. And we know that we need data to improve prevention, to help plan for action, to better assess the value of intervention. And we need data that's comparable across member states. We need data which is sufficiently coherent that we can actually ensure that it can be used by artificial intelligence systems to help aid decision, to help plan, etc. So again, diabetes is a condition that lends itself very well to being a pilot project for all of these initiatives. Diabetes makes much use of data. For people who are on insulin and who use insulin pumps and that control their blood glucose level on a regular basis, they generate a lot of data themselves. But even people who don't use, who manage their diabetes without all of those tools, an increasing number are using digital apps or are managing or improving their self-management through telemedicine, through digital health. And this also generates a lot of data. Now, for access to medicines, and particularly novel medicines, the European Commission is looking at how we can foster better innovation at a more affordable and accessible fashion. Because what we have seen in Europe is that there are huge inequalities in people's access to medicine. And that is the case across the board. In certain countries, people have to wait 2, 3, 4 years before they can access a medicine which is made available straight after authorization in some other countries. But probably the most important initiative of all is the newly launched NCD's initiative, Healthier Together. And that initiative marks a big shift in the Commission's thinking on NCDs. The Commission had been emphasizing the fact that there would be no disease-specific action other than for cancer. And last December, they released this new initiative, Healthier Together, which aims to reduce the burden of NCDs, including diabetes. And the other conditions that are part of Healthier Together are cardiovascular diseases, chronic respiratory diseases, mental health and neurological disorders. And there is a transversal strand which looks at health determinants. So the initiative was launched last December, and there's going to be a raft of consultations over the next 6 months. So either through the health policy platform for a range of stakeholders, and for member states and the Commission DGs, the consultation is going to take place via the steering group on health promotion and prevention. And so therefore, it is very important that the diabetes community comes together to provide feedback and input into this consultation, because this process is going to result in a consensus document which will be released halfway through the year and which will pave the way for the funding of specific action by the end of the year. So as I said, it is a huge and unique opportunity for us to make a real difference to diabetes in the European Union. But as it stands, the initiative is much less ambitious than the Beating Cancer Plan, for example. It looks very much like the initiative will be a guide and a toolkit for member states, rather than being a comprehensive framework with policies, with objectives, with KPI, and with evaluation. So we really call on all stakeholders to call for a more ambitious program, and we really hope that the Parliament can support us in that respect. And with this, I conclude my presentation.
Sorry, thank you so much, Sabine. That was a very comprehensive view of all the European programs. Can I ask all the panelists to please put their cameras on? That would be great, so we can address questions to you that are coming in. I think Jill, Crystal, and Sirpa, you still have your camera off, so would love to have your cameras on again, please. Thank you so much. Yeah, so Sirpa, would you like to close with your closing remarks, and then we can take some questions, Sirpa. Sirpa? There she is, yeah. Would you like to close with
some technical problems?
Yeah, no problem.
First of all, I would like to thank you, my good co-chair, Crystal Schaldemose, with whom we have a very close and good cooperation. And let me assure we both are working very hard to get as good political support and as a good presence as possible for these topics in the EU4Health program. Secondly, I would like to thank you out of these presentations, what you made very clear, what the diabetes is, quite a number of diseases, the linkage to all of the NECDs, the very clear linkage to cardiovascular disease and the others, and the big economic burden that lays to our health systems. It is very clear that this has a very strong physical, psychological, economic burden, as it was said, to individuals, but it burdens our societies. And the good news started to come after that. It is the costs on the wrong place. And if we can move up this amount of money that we are using in the later stages of diabetes to upfront on right actions to understand the diabetes, we would be very far from here. So what that would mean is, I think, besides this healthier together, the diabetes deserves upgraded EU-own program, just like we have had for cancers, we have had for rare diseases or other classes of diabetes diseases like memory disabling diseases. We need to understand that it's a complex, multifaceted and multifactorial condition that affects 10% of the EU adult population. And while it is the risk factor for other NCDs, it affects the people's living with diabetes and other conditions. It shortens their lives. And the thing what we can do is, okay, and now I'm trying to gather some of your points what you raised, prevention. And on the prevention, I'm just sort of thinking aloud a couple of points. Firstly, and this is the lifestyle comments, but that goes to greening the environment, that goes to city planning, that goes to work and family life cooperation, public transportation, the possibilities and the abilities to move in people's everyday life, and the movable life condition from the early onset in schools. But now we have the farm to fork, what you mentioned there already. And it is in huge contradict with our common agricultural policy, what we are supporting as agriculture. Should we dare to challenge our food policies beyond the farm to fork? And basically, we should only be sold healthy foods. I'm not trying to exclude chocolates or candies or treats, but we all know the amounts of sugars in cereals, in ketchups, the other components that sort of is included as one of the back reasons of unhealthy diets. And this is something that both the agriculture and the food supply chains, the stores and manufacturers should take seriously. And so I hope that we all together could challenge with the Farm to Fork program these actors to come together and working for better, healthier diets. Then on research, that is quite clear, like in other diseases, we need a lot of research. We should benefit the European data space for that, as well as speeding up the technology innovations. That goes, of course, especially to the first type of diabetes, where you need the controlling and dosing of insulin, so that we could make the innovations to make it safer and more secure and easily usable for the patients. And we would need to have in this part of this program this kind of an early intervention that you very nicely showed in your graph, one of the graphs, intervention plan, so that we screen all of the babies, we take care of the mothers, pregnant mothers, of course, but then the risk groups, be they genetical or lifestyle or with social factors, could be sort of taken under that kind of a higher and better support system early on, so that we could follow up the situation, guide with the diets and exercise and all the other factors, and also start when necessary the early onset of treatment, so that we could prevent all the drastic later onset consequences. And I don't think that this is a dream. I think that with your expertise, this is a doable thing that we just would need to put on place, to have a commission roadmap on it, to have a council conclusions, and to have national programs. And yes, that kind of an easy accessible consultation like diabetes nurses in schools, workplaces, and basic healthcare system that can facilitate, help and advise people with higher risk. So thank you very much. And now I would have millions of questions, but I restrain myself and put them later on email, maybe to be answered, and give the floor for others for questions and comments. Thank you.
Thank you so much, Irfan. Thank you to both Crystal and yourself for championing our cause across the unions. Thank you so much. So we've had a breadth of we haven't got much in the chat, and we've only got 5 minutes. So could I ask each of the participants to just summarize in kind of a minute each, what next steps they think ought to happen after this webinar? And I'm going to start with Margie, because she's the person who it affects the most. So Margie, over to you. A minute of your perspective.
I think, Niti, thank you for giving me the floor. That as a person living with diabetes, as I already mentioned, the disease is so complex that I can give you a million points to address, of course. But for me, I think that because I am in a privileged position of living in Belgium and having great access to care, it's not maybe my place right now to address environmental points. Obviously, I need to defend those too. But for me personally, I think on the point of access and innovation, I always say that it's amazing. And this weekend, again, it saved my life. But in a certain way, I definitely, the mental burden of diabetes is something that is of highly value for me. So in any case, I would definitely need help as a person living with diabetes in the decision-making aspect, but not only for me, but also my environment, my family, my friends, who are also a lot of the times desperate in how are we going to deal with this. It's not that I'm alone in it, it's also my partner, it's my parents, it's everyone that is dealing with diabetes that needs extra support, not only the people living with it, of course. So for me, I'm so happy to see that the Commission is also investing in the mental aspect of diabetes. And I think that we have other perspectives too. So
thank you, Margie. I'm going to ask Jill, because you're in a position of really launching this compact. There's a lot of programs that you've got sitting under it. Research remains a really important issue for us across Europe, and I think Chantal raised that. So from your perspective, Jill, what should the next steps be? We're a patient organization. We are the voice of people with diabetes, and how can we help you to get this across?
Thank you. I would say, I think you're already helping us. I even have a call booked with IDF tomorrow, where we regularly look at how do we work together. I think in general, we need to be really intensifying our efforts within countries to really, throughout the health system, trying to increase the efforts in terms of prevention and control, bringing together the different partners within countries and also across Europe. In the immediate next 24 hours is when the Executive Board will be discussing this set of global targets and another resolution for World Health Assembly. So those are exciting times. But also with the Global Diabetes Compact, we have, and the United Action for Better Health, the work with the EU and those present, we've got an effort to really amplify each other's work and work more strongly together, I think.
Thank you so much, Jill. And there's a question in there. Maybe you can answer that later. How's the WHO approach? I think, Mark, that's you, Mark Newman. Novo Nordisk regarding the city's changing diabetes approach, but we'll leave that question to you, perhaps to chat with each other on email or wherever. Chantal, you've said a lot. We've both said an amazing amount. I'm going to give the last, and perhaps you can put in the chat, Chantal, what you think the next steps ought to be, and you, Sabine. I'll just give the final 1 minute to Crystal. What's the next steps for you, Crystal?
First and foremost, thank you very much for your good presentations. Even though I think I know a lot, I still learned many, many good things. But mostly, I think that we can do more. So we should do more. And as we heard, there's so many things on the table in the EU at the moment: the pharmaceutical industry, the AI legislation, the health data proposal, etc. And many of these things would help people with diabetes have a better everyday life. So we should do it. We should take everywhere we can do something. We should do some. Every small step we can take, we must take. But most of all, I think I'm optimistic because it matters, and we must and we can do more. And that's what I take with me. And together with Sirpa, we will speed up and try to put diabetes higher up on the agenda here in the European Parliament. Thanks a lot.
Thank you, Crystal. With that, I draw this webinar to a close. I'm sorry if I haven't given anyone else a chance to speak. We're at the end of our webinar. Do reach out to the panelists. We're going to put this out. We're going to be disseminating on social media. There'll be a recording on social media. Please do look at it and disseminate it to all your colleagues. We'd love to hear more from you. Please remain engaged with us. Thank you so much, and thank you for your participation, panelists.